So in this podcast, we're going to be talking about suicide. We're going to be talking about the pandemic. And so just be aware that there is some triggering content here, and just take care of yourself. If you notice that you're feeling uncomfortable listening, just stop and take care of yourself. But this is hopefully going to be helpful information for you.
Hey guys, welcome back to the podcast. I'm Amanda.
I'm Laura.
Kendra.
And Laura's going to introduce us here.
Well, welcome back to the podcast, guys. And today we wanted to bring special awareness to the fact that more than 400 physicians commit suicide every year. And this month, September, is Suicide Awareness Month. And September 17th is National Physician Suicide Awareness Day. There are a lot of things in our training, sometimes in our upbringing, that can predispose physicians to be at higher risk for suicide. And it's not really talked about a whole lot. And at least it wasn't when we were doing our training. There wasn't a lot of awareness brought to it. Hopefully the training programs are doing better now. It's something that we really just wanted to bring awareness to and make sure that we all know that, yes, in fact, just being in this profession as a physician really dramatically increases our risk for suicide. And just, some ideas to help us find those amongst us who are suffering and might not be asking for help and might be showing some signs that we could pick up on and that we could extend a hand to them to help. So a lot of this information is coming from the National Physician Suicide Awareness Day website. That is npsaday.org. This website, if you're not aware, was started after an emergency physician named Dr. Lorna Breen. She was an amazing human being, incredible physician. During the pandemic, she was working in New York and doing crazy amounts of work treating people with COVID. And she was going from department to department on the same shift, not having any sleep. Anyway, she became so ill that she committed suicide. And because this happened to her and nobody could have ever seen it, friends of hers and colleagues wanted to start this website to commemorate her and to bring awareness to physician suicide. So I'm just going to share a little bit about what they say on the website about Dr. Breen. She was a sister, a daughter, a friend, and a physician. She spent her career in practice at New York Presbyterian Hospital in Manhattan and became the director of the emergency room at the Allen Hospital in 2008. She always wanted to be an emergency room physician in New York City from childhood. Everything she did was with that goal in mind, which I think is so interesting, that she wanted to be an ER doctor. I think a lot of us may have wanted to be a doctor from childhood, but I think it's unusual to hear someone say that that's what they wanted to be. She believed that medicine and helping people was her calling. She was passionate about patient care and was always looking for ways to improve the patient experience. When not caring for patients, Lorna loved to travel the world. She had a close group of friends in New York and was an active member of her church. She was an avid snowboarder, salsa dancer, and the cool aunt to 8 nieces and nephews. Despite the fact that there were a million reasons not to, she drove a convertible sports car, which I think is awesome. It's just you can see the kind of personality she had. She was a vibrant, loving, amazing human being. She drove that sports car because it made her happy.
Lorna unfortunately died by suicide on April 26, 2020. In a period of 3 weeks, Lorna treated confirmed COVID patients, contracted COVID herself, and returned to an overwhelming, relentless number of incredibly sick patients. Lorna and her colleagues worked around the clock during the peak in New York with limited PPE, insufficient supplies, not enough oxygen, not enough beds, not enough help, which we heard this resoundingly from many areas, but the Northeast did get hit hard in the early stages. They had patients dying in the waiting room and the hallways, which once again was a resounding repeat from many different EDs across the country that got really hit hard all at once. After 12-hour shifts, Lorna would stay, as would her coworkers too, because the onslaught didn't slow throughout the day or night. When Lorna left the emergency department, she had to take the train home. As the trains were largely empty due to the distancing measures, she was afraid of being mugged. She tried to take cabs home, but some of the cabs stopped taking people that were leaving the hospital for fear of being exposed to the virus. In spite of all that, she kept going back until she literally could no longer stand.
So on April 9th, 2020, Lorna called Jennifer, and we're assuming this is one of the friends who started the website, but we're not 100% sure. But she called Jennifer from her home in Manhattan to tell her that she couldn't get out of her chair. She was nearly catatonic. She hadn't slept in over a week, and she'd been working 12-hour shifts, staying well past the end of each shift. And during one of the shifts that she covered, she ended up covering 2 emergency rooms in Manhattan at the same time, at locations that were 5 miles apart. I can't even imagine.
No.
Oh my God. She answered the call for her city and for her country. And when she became so overworked and despondent that she was unable to move, do you know what she was worried about? Her job, because that's what we do. She was worried that she would lose her medical license or be ostracized by her colleagues because she was suffering due to her work on the front lines of the COVID-19 crisis. She was afraid to get help. This is something we hear over and over, because she was worried that it would end her career, the career that she had spent her entire life working for. And at the time, we thought her fears were unfounded. But what we learned after her death is that licensing boards throughout the country require disclosure by physicians of current or past mental health care, in some cases at any level. And hospitals require disclosure for credentialing, and seeking mental health care is considered a sign of weakness amongst many medical professionals.
Which I think that this rising generation, I don't know necessarily of people training in medicine, but this rising generation of young people recognize the value of receiving mental health care. And really, it's probably something that people should be using just like they use the dentist, at least, like just go and see what thought errors you have picked up over the last 6 months, just
like this is no longer acceptable. Like the old school way of doing it is not, it is not working, and it has to change. This is absolutely ridiculous. The amount of secondary trauma that we get for our jobs, it should come standard with mental health support. And almost like you have to opt out, like you required or something, because it's just not sustainable.
Not only not sustainable, but it is so damaging. Like this job is really mentally dangerous if you're not getting that kind of support, because we think it's normal. We think it's normal to go see people's, limbs ripped off on every day, or overdoses or gunshot wounds every day, and it not affect us. It's a lie. And a lot of times we don't know until it catches up with us in situations like this. So she had no prior mental health issues known or suspected. She had no history of depression or anxiety. She was very smart, of course, very funny, like all ER docs, just about, and had just the right amount of sarcasm, which is interesting because we use that and it's not always a sign of great mental health either. But after she died, we learned that in the United States, 400 physicians die each year by suicide. If you think about that, people really think about being an American physician is like the American dream. You've got this well-paying job, respect from the community, supposedly, and respect from your peers. And so why would it be? Why would it be that we have such a high suicide rate? Female physicians die by suicide at a rate higher than their male counterparts. Curiously, just want to talk about that for a minute. What thoughts do you guys have on why that might be? Why women physicians might have an even higher rate of suicide than men?
I guess I have a lot of thoughts, but I don't know. Do we know for sure why? I don't know.
But I could guess that not only do they have their job, but they take on so many other roles in life that it might be easy to have more of a sense of overwhelm. It might be easy to not want to be a burden on other people, want to just kind of keep their struggles to themselves.
I think that's true also because we're stepping outside of norms still a little bit. I mean, not as much now, but still we're stepping outside of norms. You definitely see people who are in more traditional female roles, and then to do that and then struggle doing it. I don't know if we judge ourselves and don't lean on people because then they're like, well, you shouldn't have done that in the first place. You know what I mean?
Right, right.
Yeah.
The great advice that we get all the time is suck it up, buttercup.
You signed up for this.
This was your choice.
Just don't, right?
Now I have $400,000 of debt, so now what am I supposed to do?
I think there is, we've talked about this before. I think that silent suffering is a big part of it. I think, women in general, I think some of our programming is we always are looking to the right and the left, especially at other women. And if we think that the woman to our right and left has it all together, or some kind of lie that we tell ourselves because it looks like on the outside they have it all together and they're like handling it, they're also probably suffering in silence because, God forbid that we actually admit that we need help because we did embark on this professional career and it's a both and we want to be a mom and a wife and a home executor and cook dinner and whatever else that we also enjoy to do. And so is there maybe a thought that I brought this all on myself, like I signed up for this, or people I should be able to, and I should be able to handle all this. When in reality, women more than anything are the best at creating community. And I think a lot of, or not a lot, but I would say the motivation we talk about all the time is we need community. And what better than to be in community with women who are doing all the things and share, like, how do you do this? What do you do when you have a bad day? What do you do if you haven't had sleep? And just talking about it, like make conversation and community normalized. But I think that's probably my biggest, when I think back to when I was struggling the most, it was in silence. It was in isolation, thinking that something's wrong with me. I should be able to handle this. Looking at women that have gone before me and they did it. They made it out alive, kind of thing. What do I not have? What am I lacking? I think that's another thing, that self-critic. What am I lacking that I haven't been able to do this? What do I not have? What tools, what characteristics, whatever. You start questioning your own ability to do the thing when it was like, wow, what you're trying to do is a little superhuman. Not sure anybody has all that.
I think a better term for that I think a lot of us, just from all the people that we have interacted with, is we tend to have a healthy dose of pathologic altruism.
Yeah.
And, a lot of our doctors in general are at risk for suicide, but women, like we just saw, especially so. A lot of our male counterparts have a spouse that is able to be a lot more supportive. A lot of women physicians are either the single provider or more often are also married to another physician who both need support and both aren't able to give it to each other because we just tend to put medicine first, which isn't, I'm not saying I actually don't think that's a very good thing, but
no, but we've both been through the same system and have
so
the
you're
same,
both right. So you're both not getting support at home, really. And then women physicians, even still today, the statistics suggest that we are doing a preponderance. We're working at work and then we're also full-time working at home.
Right.
Like there isn't any, now I get to shut it off and somebody else handles it from here. That doesn't exist as much for us.
No. And when you hear these stories, like this story and the story of Gretchen Butler, which we had a previous podcast on, we'll link that. What the biggest factor that I see that brought the suicide on was overwhelming fatigue, overwhelming exhaustion, and their brain just stops being rational.
But this whole thing of it works on us for some reason, but who will do it if you don't? Well, guess what? Gretchen's hospital didn't shut down the next day, nor did Lorna's.
Nope.
And somehow we have this internal control factor where I don't know, we get delusional that it is all up to us. Probably the lack of sleep and just the pathologic altruism, that it's would it be better to call off and sleep one time and then, as opposed to not be, what I mean? They had to fill all of your shifts after.
Right.
It's just not, it's not coherent thinking.
No,
sadly, but you can't when you're exhausted.
No, when you're so exhausted, and honestly, your brain has been jacked up anyway, just by other things happening in your training and at work. And I would imagine they feel powerless. It seemed like in this situation, they feel powerless. And the idea of getting help would sound like I'm actually giving away, I'm possibly giving away more power. Like I'm putting my ability to earn a living at risk to get help. I don't know. It's a lot. There's a lot of things at play here. And we need to do a better job of making sure that we take care of ourselves and that our colleagues are taking care of themselves. So this stops. This was interesting and not surprising, sadly. They said that they learned that the specialty of emergency medicine has one of the highest suicide rates of all medical specialties. And
I've got to believe that's why when they publish those statistics of how long each specialty lives, and emergency medicine is wildly skewed.
It was like 57 or something.
It has to be from extremely young people, you know what I mean, that are skewing it. Like suicides, I would think would be an explanation of that. It would skew the age younger. Plus our shift work is just toxic anyway.
Yeah, the shift work, that's one of the things that will jack your brain up. For one, because you're never having enough sleep. So we all need to make it part of our mission as medical providers to prevent physician suicide. I mean, I would argue that this is more important than patient care, is to look at ourselves and around us and make sure that we're all okay. Because if we're not okay, we can't take care of our patients. We can't keep showing up. If we're dead, we're definitely not showing up. I think you guys probably have some things that come readily to mind to say to people who might be feeling bad, or obviously if you're feeling suicidal, go get help. We also want you to recognize some of the thought errors you might be having that could be contributing. Like, this is my job. This is who I am. No, this is not who you are. This job is not who you are. And if it is killing you, you need to take a break. You are a beautiful human being who is loved and incredibly valuable, no matter if you decided to go be a cartoonist down on the pier, or if you decided to be a garbage collector. You are incredibly valuable. This job does not add anything to your value, and leaving it does not take any of your value away. And going to get some sleep doesn't make you less valuable. Getting some help doesn't make you less valuable. Our brains, bless their little gray squishy hearts, they try to keep us alive. They try to keep us safe by telling us all the things we need to not do to avoid social rejection. But it's just wrong. It's just flat out wrong a lot of the time. So just pay attention. So they created a HEART acronym to help us be able to see the warning signs to look for in someone who may be suicidal. HEART, that's for like health, emotions, attitude, relationships, and temperament. And we're just going to explain a little bit more about each of those.
So vital sign 1 in that HEART acronym, or H standing for health, is noticing an increased use of medications, alcohol, or illicit drugs. And sometimes this is a little, stealthy and you're not 100% sure, but you do notice maybe making some alluding comments about feeling hopeless, or just maybe making a general statement like not wanting to be here. And, all of us say like, I didn't want to come to work today. I don't want to be here today. Like in general, we joke about it. Maybe we're going from nights to days, and it's just a rough transition, but you can kind of tell if they make a kind of statement that's a little bit more, the temperament usually matches a statement of hopelessness. And so just recognizing too that even if you're not going home with this person or knowing what they're always doing in their free time, you do kind of notice a difference in temperament. If alcohol or illicit drug use is starting to ramp up, you can kind of start to notice in that. And then vital sign 2, HE is emotions. So these are those mood swings. And this is kind of what I was alluding to when we talked about the first vital sign, is that feeling of hopelessness or no purpose. So their whole countenance change and the way they hold their body changes. So you can kind of notice how they're walking into work, and then just noticing maybe their interactions with like nurses, techs, or other colleagues, that kind of starts to change. And while we can have a bad day here and there, and you can kind of recover, this starts to be a persistent pattern. And then vital sign 3, HEA, A is for attitude. And this also goes along with that, being negative about professional and personal life, inappropriate outbursts of anger or even sadness. And it typically manifests as like an overreaction. So an overreaction on the floor, an overreaction to a seemingly stable patient or stable situation that seems to be out of character for that person to lose their cool when they're typically can handle patients and handle stressful situations. And then you just start to notice that threshold kind of drop, get lower and lower.
These two stories that we've talked about, Lorna Breen and Gretchen Butler, they, from everything we can see, they really gave no signs except for calling. They called colleagues and said they were tired. And Gretchen did the same thing. She was like asking for help covering weekend call. She was a radiologist. She was just so exhausted. So that could be our only red flag, is that someone is saying that they are overwhelmingly exhausted. I recently went and visited one of our residency classmates' ER groups, and he reminded me, he's like, I just remember when we were in residency and I called his wife because he's such a funny guy. He's hilarious. And I was like, hey, is he okay? Because he's not joking as much as usual. And he's like, I just remembered that, like that you noticed that. So it could be very, very subtle. Like you're not going to necessarily see and I don't think he was suicidal at the time, but he was having a hard time. So it can be subtle. It might not be someone's coming in looking like Eeyore. They might just be a little off, or might just be saying they're super tired.
Okay, so vital sign 4, the R in heart, is relationships. It makes zero sense because the most healing thing that we can do is connect with others. But when we're in this state, we start withdrawing and isolating from family and friends. Honestly, these people really feel like on some level that this is the only way to escape, or that the world is better off without them. So they start turning inward rather than outward. And they might start talking about being a burden to others, or I wish I only knew what it was that Gretchen and Lorna were thinking. But like objectively in a well-slept state, that doesn't make any sense. But when you are really when you're in it, your brain is telling you these things that aren't true. But watch for that. Isolating. In emergency medicine, our scariest patients are the ones that become suicidal and then energized. Like they're excited that they finally have the energy to finish it all. But before that, they tend to be so exhausted while they're still making their mind up. And then the 5th vital sign is temperament. So acting anxious or agitated, behaving recklessly. This might be the suicidal people that are up. Like that can be a real scary thing when they suddenly found this newfound energy to actually complete it. Being uncomfortable, tired, or an unbearable pain. So think about, what are the warning signs, thoughts, images, moods, situations, behavior that a crisis is developing. And so if you go to the website, which is, again, npsaday.org, there's a little worksheet for physicians to fill out ahead of time. So do that while you're having a good day. And some of the things you want to start thinking about is, what are my warning signs? What are the thoughts, images, moods, situations, behavior that should trigger me that maybe I'm getting into a crisis situation? Maybe there's a crisis developing. Next, who are a few people, or what are the social settings that can provide me with a distraction? They suggest this for like relief workers and people who are in situations that are overwhelming, and you are going to have days where you feel like there's not a lot that I can do and like hopeless about it. It is a good strategy to maybe hang out with some people that aren't doing the same thing and talk about some other things, or go see a movie or something. You're allowed a respite. And I mean, Mother Teresa, every 7th year would send her nuns, like they would get a sabbatical for a year, because there's empathy fatigue. There's like bone tired exhaustion, and you do deserve that time to repair. Think about, which people can I ask for help? who are the professionals or agencies that I can contact during a crisis? And we'll give you some suggestions. One is your primary care doctor. Another is, a psychiatrist or counseling or a clinical psychologist, somebody like that. Because of the COVID crisis, there is now a psychiatrist-staffed anonymous physician support line. It is physiciansupportline.com. The phone number is 1-888-409-0141. That is an amazing resource that didn't exist before COVID. It's actually now a nonprofit too, if you feel like donating to that. And then you can contact your hospital employee assistance program. Not only just for physicians, now the United States has a crisis line. So you can always dial 988 or chat on 988lifeline.org. All of those are options. So please remember that before you were to make a permanent decision about something, to at least talk to somebody.
Yeah, there was a list somewhere, and I couldn't find it for this, but it was like things to do before you hurt yourself. If you're feeling like this, things to do. And because obviously physicians might get themselves off by themselves and not want to talk about it to anyone. But if you're feeling really, really depressed, some things to do: take a shower, take a nap, have a snack, go outside and sit in nature for a minute, call a friend, look at some pictures of people you love. Call your doctor. We say this all the time. We're doctors, we're not your doctor. But this is something like if you are feeling the least bit of mental health struggle right now, please call your doctor and start a conversation about what needs to happen to feel better. There are so many things that can be done to help you feel better. And so much of this is likely situational. If you're a physician, a lot of it can be just taking a break and taking a nap, or, taking a vacation or sabbatical can help so much, and also getting some mental health support. So please do that. There's also ketamine. Those of us who work in the emergency department who have, I use this on patients who are suicidal. I wouldn't say I do it all the time, but I probably once every couple of months I'm able to do it. And if it's somebody that I feel like it's uncomplicated enough and they're still getting admitted to the hospital and they're not already on a bajillion meds, then I'll do a ketamine infusion, and it is amazing. It's amazing. It's a little reboot for the brain. And so that is available to a lot of people in their communities. We have an infusion clinic, we have a couple of them in our community where you can go and do that. There are so many better things to do than to isolate yourself and hurt yourself. So please just know, if your brain is telling you the world is better off without you, that is a flat out lie. That is not true. Suicide creates negative ripples for generations. It creates generational trauma. And, even when I hear about a kid from the local high school committing suicide, I didn't even know this kid, but it affects me in such a profoundly negative way. This is not the legacy we want for ourselves. So please just get the help that you need, and don't allow that to become your legacy. And check in with your friends, check in with your colleagues, because obviously people can be looking like they're doing fantastic and they're just not. So please just check in with each other, and let's give each other that kind of care, the excellent care that we give our patients. Let's give it to each other too.
Yeah, that's a great point, Elle, that we always strive to give excellent patient care. Caring for each other should never fall short of that. Just the same precision with which we go to work every day and diagnose, prognose, treat, all the things, we can also care for each other with that same precision and excellence. So those are some great points. And so we hope this has helped. We know it's not a very fun topic, but a very essential topic to talk about and bring awareness to. If you think of someone, if this has triggered just someone to come into your mind, that's for a reason. So as you've listened to this podcast today, if someone just came up into your mind, why don't you send them a text as soon as we're done today, or call them later, or there's a reason they came to your mind. And so if something resounded in this podcast, as we always say, leave us a review, give us stars and a review, because we do want podcasts like this to exponentially be heard. And so it will help other doctors find us, but it also helps get the word out. And awareness is one of the things that really empower us to do something. And so until next time, you are whole, you are a gift to medicine, and the work you do matters.
So in this podcast, we're going to be talking about suicide. We're going to be talking about the pandemic.